Imagine, a subtle change in your mouth, maybe a sore that just won't go away, or a little red patch you just brush off as irritation.
Mm-hmm.
What if that tiny thing was actually the first sign of something much more serious, like oral cancer?
It's a scary thought, and it happens.
Yeah, and if it's caught late, the journey, well, it
Well,
can be incredibly tough, right? With serious side
well,
effects.
absolutely. Which is why knowing those early signs, understanding how it's diagnosed and what treatments are out there isn't just like good information.
It's critical, really critical for your health.
Exactly.
Welcome, everyone, to vpod.ai. Today, we're diving deep into oral cancer. Our mission is to give you a real shortcut to being properly informed on this really vital health topic.
We'll be covering, the basics, what it is, where it tends to show up.
How doctors figure it out, the latest treatments, and yeah, what you can actually do about prevention and staying healthy long term. And this deep dive is sponsored by Stonefly. They're your trusted solution provider and advisor for all things enterprise storage, backup, disaster recovery.
Right, and hyper-converged solutions like VMware, Hyper-V, Proxmox clusters.
Plus AI servers, the SA365 turnkey security appliance, and publish in private cloud services. You can check them out at stonefly.com for more info.
So, okay, oral cancer. Let's unpack that. It falls under the umbrella of head and neck cancers, specifically hitting the mouth, or what we call the oral cavity.
And it's not just like one spot, is it?
No, not at all. It can pop up on your lips, the front part, about 2/3 of your tongue, your gums.
Inside your cheeks and lips, too.
Yep, the lining there, that's the buccal mucosa. Also the floor of the mouth right under the tongue. The hard palate, that bony bit at the top.
Even near the teeth?
The bony ridges holding your teeth, yeah, the alveolar ridge, and even that little spot behind your wisdom teeth, the retromolar trigone.
Wow, okay. So pretty much anywhere in there.
Pretty much. But the key thing, I think, is that most of these cancers start in the surface cells, which means looking carefully, doing those routine checks is actually really powerful.
That makes sense. So if it can show up in all these places, is there one type that's, way more common than others?
Yeah, the vast majority, we're talking around 90%, are squamous cell carcinomas, SCCs.
Squamous cells, those are the flat ones lining things.
Exactly. They form in those thin, flat cells that line most of your mouth. So yeah, it can affect the soft linings and the tougher surfaces you use for chewing. No area is really safe, unfortunately.
Got it. And prevalence. Are the numbers surprising? How common is this, really?
They can be quite striking, actually. In Germany, for instance, about 1/10 of all malignant oral tumors are found on the floor of the mouth. That's maybe 1,200 people a year.
Okay.
But then you look globally, and it varies massively. In the U.S., it's maybe 5% of all cancers. Go to India, though, and that number can shoot up to 50%. 50%.
50, wow, that's huge.
Oh,
What
yeah.
causes such a difference?
A lot of it comes down to lifestyle factors. Cultural habits, like betel quid chewing in places like India, play a massive role. It's a really stark reminder, that things we do every day can dramatically change our risk.
Really makes you think about prevention differently.
It does. And it's also worth noting it's significantly more common in men. About 3/4 of cases usually diagnosed between 55 and 70 years old.
That 5% to 50% difference is just, yeah, eye-opening. Really drives home the lifestyling. Okay, so if it's often subtle early on, what are the absolute key warning signs we should all be looking out for? What's the heads up?
That really is the crucial question, isn't it? Because early on, it often doesn't hurt. That's the tricky part.
So what do you see?
Well, the most common first sign is often an ulcer or sore that just won't heal.
Mm-hmm.
But you also need to watch for any red or white patch that sticks around.
Red or white patches?
Yeah, the white ones, we call them leukoplakia, can actually turn into cancer in maybe 20% of cases. And the red ones, erythroplasia, often have links to HPV.
Okay, what else?
Other early things could be swelling that keeps getting bigger, teeth suddenly becoming loose for no obvious dental reason.
Loose teeth, really?
Yeah, without gum disease or something else explaining it. Also, any unusual bleeding in the mouth or even nosebleeds, hoarseness that lasts a long time, or just finding a hard sort of thickened spot somewhere in your mouth.
Okay, let's unpack this. A lot of those sound like things I might just ignore, like a canker sore maybe,
Yeah.
or just biting my cheek.
Exactly. And that's the danger. What's fascinating, or maybe worrying, is how much these early signs overlap with common, harmless things.
So how do you tell the difference? What should listeners really focus on?
The key thing, the absolute takeaway is time. A typical canker sore in aphthous usually gets better on its own within, say, a week or two.
Right.
So if you have any sore, patch, swelling, or weird symptom in your mouth that doesn't clear up by itself or respond to normal treatment, within 2 to 3 weeks, you have to get it checked out.
2 to 3 weeks, that's the benchmark.
Consider it potentially serious until a professional tells you otherwise. Don't just wait and hope it goes away. Don't assume.
That's such a vital point. Okay, so those are early signs. What happens if it progresses? What are the later symptoms?
As it gets more advanced, symptoms can become more pronounced. Things like numbness or tingling paresthesia on your tongue or lips.
Numbness.
Yeah, or difficulty opening your mouth fully. That's called trismus. Trouble swallowing, dysphagia, that can happen too. A persistent earache on one side maybe, or swollen glands, lymph nodes in your neck that don't go down.
Are there other more general signs?
Yes, sometimes things like changes in vision, pain that seems to spread or refer elsewhere, really persistent bad breath, or just feeling generally unwell, tired, losing appetite, lethargic. Those can also be later indicators.
So if someone spots any of these signs, the early ones or the later ones, what's the first step? Who do they call?
Your first port of call should probably be your family doctor or dentist. They can do an initial assessment. Or you could go straight to an ENT, ear, nose, and throat specialist.
And then they'd refer on if needed.
Exactly. Oral and maxillofacial surgeons and ENTs are usually the specialists you'll be referred to for a more in-depth look.
What does that initial specialist exam actually involve? What are they looking for?
It's a really thorough check. They'll look carefully, using a good light and mirrors at all the surfaces inside your mouth and throat. But they'll also feel things.
Palpation, right.
Yes, palpation. They'll gently feel your head and neck for any lumps or bumps, especially checking the lymph nodes in your neck. And they'll do what's called bimanual palpation for areas like the floor of your mouth and your tongue. That means using fingers both inside and outside your mouth to feel for any hardness or thickness.
Sounds quite comprehensive.
It has to be. They might use a piece of gauze to gently hold your tongue and move it around to see the size in the very back, areas that are hard to see otherwise.
Okay, so they do the visual check, the feeling around. What comes next to actually confirm if it is cancer?
Well, the definitive diagnosis, the gold standard, always comes down to a biopsy.
Taking a tissue sample.
Precisely. They'll take a small piece of the suspicious area that's an incisional biopsy. Or if the lesion is small, they might remove the whole thing, which is an excisional biopsy, usually just done with some local anesthetic, numbing the area.
Here's where it gets really interesting for me. Besides the biopsy, what other tools help them? Especially with figuring out where exactly to biopsy or seeing how far something might have spread.
Great question. There's some really helpful adjuncts. One simple one is toluidine blue dye.
A dye, how does that work?
It's basically a stain that you swish around or they apply directly. It selectively sticks to cells that are abnormal or cancerous because those cells tend to have more DNA activity, so it kind of highlights the suspicious spots.
Ah, so it guides the biopsy.
Exactly. It's simple, low cost, non-invasive, and helps make sure the biopsy is taken for the most representative area. It's actually pretty sensitive and specific.
Okay, and what about imaging, like CT scans, MRIs?
Right. Imaging is crucial for seeing what's going on deeper down and checking for spread. CT scans are generally better for looking at bone. So if they suspect the cancer might be invading the jawbone or to get a good look at lymph nodes, CT is often preferred.
And MRI?
MRI gives much better detail of soft tissues. So for seeing exactly how far a tumor has spread within the tongue or cheek lining, or looking at areas like the back of the nose or sinuses, MRI is usually the way to go. It gives that nice 3D picture.
So they complement each other.
Very much so. CT has limits with soft tissue detail and can have artifacts from dental fillings, while MRI isn't as good for fine bone detail and can be affected if the patient moves. Often they're used together.
And TT scans, I hear about those too.
PT-CT scans use a radioactive sugar tracer, FDG. Cancer cells tend to gobble up more sugar, so they light up on the scan. This is really useful for finding cancer that might have spread to lymph nodes or even distant parts of the body, especially if other scans aren't totally clear.
Any other tools?
Well, panoramic dental x-rays give a good overview of the jaws and teeth. And while just scraping cell cytology isn't enough for diagnosis on its own, a fine needle aspiration, or FNA, is very useful.
What's that for?
FNA is where they use a thin needle to take cell samples from lumps you can't easily see, like a suspicious lymph node in the neck or a mass in a salivary gland. It helps figure out what's going on under the surface.
Okay, so once the diagnosis is confirmed with a biopsy and they have the imaging, the next step is staging, right? Understanding how advanced it is.
Exactly. Staging is critical. It helps predict the likely course of the cancer, the prognosis, and guides the treatment plan. We use the AJCC staging system, which relies on the T&M classification.
TNM. TNM. Can you break that down?
Sure, T stands for tumor. This describes the size of the primary tumor and, really importantly, how deeply it is invaded into the surrounding tissues. There's a specific measure called depth of invasion, or DOI.
Why is DOI so important?
Because the deeper it goes, the higher the risk that cancer cells have escaped into the lymph system. The T stage ranges from T1, which is small and superficial, up to T4B, where it's invading major structures like the base of the skull or main arteries.
Okay, that's T. What about N?
N is for nose the lymph nodes. This indicates whether the cancer has spread to the regional lymph nodes in the neck. It looks at how many nodes are involved, their size, and critically, whether the cancer has broken out of the node capsule. It's called extranodal extension, or ENE plus A, which is a more serious sign.
Which nodes are most commonly affected?
Usually the ones in the upper parts of the neck, levels 1, 2, and 3, are at the greatest risk initially.
And finally, M.
M is for metastasis. It just indicates whether the cancer has spread to distant parts of the body. M0 means no distant spread. M1 means it has metastasized.
Where does it typically spread if it does?
The most common distant sites are the lungs, bones, and liver.
So when you put T, N, and M together, you get the overall stage. How much does that stage impact the patient's outlook?
Hugely. If we connect this to the bigger picture, the stage of diagnosis is probably the single strongest predictor of prognosis, especially the N status, the lymph node involvement.
How big a difference does it make?
Well, roughly speaking, if the cancer hasn't spread to the lymph nodes, the 5-year survival rate is somewhere around 70%. But if it has spread to the nodes, that can drop dramatically, down to maybe 20–25%.
Wow. That's a stark difference. Are there other things, maybe things they see under the microscope in the biopsy that also affect prognosis?
Absolutely. Beyond the T&M stage, certain pathological findings are really important. Things like perineural invasion, that means cancer cells are seen growing along the nerves.
Okay.
Or vascular invasion, where cancer cells are found inside blood vessels. Both of those suggest the cancer is more aggressive and more likely to spread.
And the cells themselves, do they look different?
Yes, the grade of the tumor matters, how differentiated the cells are. Poorly differentiated tumors mean the cells look very abnormal, very different from healthy cells, and they tend to grow and spread more quickly. These factors, advanced stage, perineural or vascular invasion, poor differentiation, are all independent predictors of survival.
Given how complex this all is, the staging, the pathology treatment must involve a lot of different experts, right?
Oh, absolutely. Treating oral cancer effectively really demands a multidisciplinary team approach, an MDT. And ideally, this happens at a specialized cancer center with experience.
Who's typically on that team?
It's quite a list. You'll usually have otolaryngologists, ENTs, and oral and maxillofacial surgeons doing the surgery. Often plastic reconstructed surgeons are involved too.
For rebuilding things?
Exactly. Then you have medical oncologists who manage chemotherapy and other systemic drugs.
Yep.
Radiation oncologists for the radiation therapy.
And support staff.
Crucially, yes. Oncology nurses, dietitians or nutritionists, speech and language therapists vital for swallowing and speaking, plus psychologists and social workers for emotional and practical support. It takes a village.
So what are the main ways they actually treat the cancer? What are the core treatments?
Surgery is often the main treatment, especially for cancers that haven't spread distantly. The goal is always to remove the entire tumor with a clear margin of healthy tissue around it.
To make sure they got it all.
Precisely. And surgery often includes dealing with the lymph nodes in the neck, too. That might mean a neck dissection, removing groups of nodes, or sometimes a sentinel lymph node biopsy first to see if the cancer has spread to the very first nodes it would likely reach.
What about reconstruction after surgery, if they have to remove part of the jaw or tongue?
That's where the reconstructive surgeons come in. They can do amazing things now, using tissue from other parts of the patient's body, maybe bone from the hip or shoulder blade, skin and muscle flaps to rebuild the removed areas.
Using the patient's own tissue?
Often, yes. It frequently involves microsurgery, connecting tiny blood vessels to make sure the transplanted tissue survives. The goal is to restore function, chewing, swallowing, speaking, and also appearance as much as possible. Later on, dental implants or specialized dentures might be part of the plan too.
Okay, so surgery's key. What else is in the toolkit?
Radiation therapy, or RT, is another cornerstone. It uses high-energy rays to target and kill cancer cells. Modern techniques like IMRT allow them to shape the beams very precisely.
Is it used alone?
It can be, or it's very often used after surgery to kill any remaining microscopic cells, or sometimes it's combined with chemotherapy that's called chemoradiation, and it makes the radiation more effective, though often with more side effects.
And chemotherapy is a systemic therapy.
Yes, systemic means it travels throughout the whole body. Chemo drugs kill cells that divide rapidly, which includes cancer cells, but also some healthy cells, leading to side effects.
Are there other systemic options besides traditional chemo?
Yes, definitely. Targeted therapy drugs are designed to attack specific molecules or pathways involved in cancer growth. And immunotherapy is a really exciting area. These drugs help unleash the patient's own immune system to recognize and fight the cancer.
And clinical trials.
Always worth considering, especially for more advanced or recurrent cancers. Clinical trials are how we test new treatments and improve care, so they offer access to potentially cutting-edge therapies.
So what does this all mean for the patient going through it? It sounds like a lot. Let's talk about the side effects and the support available.
Yeah, it's really important to be realistic. All these treatments, while aiming to cure the cancer, can unfortunately cause side effects, and some can be quite serious or long-lasting.
It varies a lot, I imagine.
It does, depending on the specific treatments, the location and extent of the cancer, and the individual patient. But the crucial thing is communication. Talking openly with your care team about any side effects you're having is so important because they can often help manage them.
What are some of the most common things people experience?
Given where the treatment is focused, difficulties with eating and swallowing are very common. Dysphagia is difficulty swallowing. Odynophagia is painful swallowing. Speech can also be affected.
And dry mouth. I hear that's a big one.
Huge. Xerostomia, or dry mouth, happens when the salivary glands get damaged by radiation. It's often a long-term, sometimes permanent, side effect and can significantly impact quality of life, taste, and even increase the risk of cavities.
What else?
A sore mouth and throat are common during treatment. Fatigue is almost universal with cancer treatment. Loss of appetite, changes in taste like that metallic taste you mentioned, and skin reactions in the treatment area like redness or soreness are also frequent.
Are there longer-term effects to be aware of, too?
Yes. Lymphedema swelling, usually in the neck or face, due to disruption of the lymph drainage system can sometimes develop and might be persistent.
Anything else serious?
A rare but serious late effect of radiation can be osteoradionecrosis, which is damage and potential death of the jawbone. It can happen years later. And as I mentioned, the risk of dental decay is higher, especially with persistent dry mouth.
What about nerve damage?
That can happen too. Cranial neuropathy is damage to the nerves controlling sensation, facial movement, vision, hearing, swallowing, speech, can occur depending on the tumor location in treatment fields.
And the emotional toll.
We absolutely have to acknowledge that. Going through diagnosis and treatment for oral cancer is incredibly stressful. Distress, anxiety, depression, sleep problems, these are very common and understandable reactions. Getting psychological support is a key part of the care plan.
It sounds like managing these side effects and emotional impacts is just as important as treating the cancer itself.
It absolutely is. That's where supportive care comes in. Sometimes it's called palliative care, but it's not just for end of life. It's provided right from the start, alongside curative treatment.
What's the goal of supportive care?
The goal is simply to prevent and relieve suffering and improve quality of life throughout the entire process. That means managing pain, nausea, fatigue, mouth sores, swallowing problems, emotional distress, everything that impacts the patient's well-being.
So it's integrated care.
Exactly. And it also includes encouraging active self-care. Simple things like trying to eat well, staying hydrated, getting gentle exercise when possible. They can make a real difference in how you feel and cope during treatment.
Okay, finally, let's circle back to prevention. We know the signs, we know the treatments, but what can we all do to lower our risk in the first place and stay vigilant?
This really raises that important question, doesn't it? How much control do we have through our choices? And the answer is quite a lot, actually.
So number one is?
Without a doubt, quitting tobacco. Smoking cigarettes, cigars, pipes, using smokeless tobacco, it's the single biggest risk factor. And heavy alcohol use is right up there too.
And the combination is particularly bad.
Extremely bad. Smokers who also drink heavily have a risk that's many, many times higher. Some studies say up to 30 times higher than people who do neither. So cutting out tobacco and limiting alcohol is absolutely fundamental.
What else beyond tobacco and alcohol?
Regular dental checkups. Seriously, your dentist is on the front line. They're trained to spot suspicious changes in your mouth, sometimes before you even notice them. They can also address things like poorly fitting dentures that might cause chronic irritation, which is another potential risk factor.
So don't skip those dental appointments.
Definitely not. And related to that is checking your own mouth regularly.
Self-exams.
Yes. Maybe once a month, take a good look inside with a bright light in a mirror. Check your tongue, top, bottom, sides, the roof of your mouth, inside your cheeks, your gums, under your tongue. Get familiar with what's normal for you so you'll notice if something changes.
That seems very empowering.
It is. And finally, just fundamental, good oral hygiene. Brushing properly twice a day for at least 2 minutes.
3 minutes you mentioned earlier.
Right. Thorough brushing. Cleaning between your teeth daily with floss or interdental brushes, and maybe even scraping your tongue daily. It all helps maintain a healthier environment in your mouth.
Okay, so prevention is key. What about after someone has been treated? Does the need for vigilance ever end?
No, unfortunately it doesn't. Lifelong vigilance is really important for oral cancer survivors. Regular follow-up appointments are absolutely crucial.
Why is that?
For two main reasons. One is to monitor for and manage any long-term side effects of the treatment. The other, critically, is to watch for any signs that the cancer has come back recurrence or for the development of a new second cancer.
Is that common? A second cancer?
Sadly, survivors of head and neck cancers do have a significantly higher risk of developing another cancer, often in the head and neck area again, or sometimes in the lungs or esophagus, often related to those same risk factors like tobacco and alcohol. So continued monitoring is essential.
This has been incredibly thorough. We've covered so much ground really understanding what oral cancer is, where it hides.
The absolute importance of spotting those early, often subtle signs, and that crucial 2 to 3 week rule.
Right. And then demystifying the diagnosis, the exams, the biopsies, the different types of imaging.
Understanding what TNM staging actually means for prognosis and those key microscopic factors like perineural invasion.
And the treatments in the multidisciplinary team, surgery, reconstruction, radiation, chemo, targeted therapies, immunotherapy.
Plus, navigating the side effects, the vital role of supportive care, and of course, prevention and lifelong follow-up.
The main message, I think, is really clear. Catching this early makes a world of difference. And being informed about the signs, the process, the options, it really empowers you to take control of your health.
Absolutely. Knowing what to look for, knowing who to see, and actively participating with that multidisciplinary team throughout the journey is key.
So maybe a final thought for everyone listening. Just consider how those small, consistent acts, checking your mouth, seeing your dentist, making healthier choices, how those seemingly simple things can genuinely shape your future, especially when you're dealing with something as potentially serious as oral cancer.
Well said. It's about being proactive.
Before we wrap up, just a reminder to check out Stonefly. They're offering a 100 TB immutable and air-gapped SSO NAS for $8,995. You can find all the details at stonefly.com. Thank you so much for joining us for this deep dive.